morning, everyone, again. That was a great presentation just now. So thank you to the presenter. My name is Dr. Kumaran, and this morning I have the pleasure of introducing Dr. Chung Tze Yang from the Department of Rehabilitation Medicine. Dr. Chung has requested a very brief intro. So he says that he has been working since 2008, more than 10 years, and he runs the neurorehabilitation and amputee rehabilitation clinics in UMMC. So the topic of Dr. Chung's presentation today is promoting neuroplasticity for motor recovery post-stroke. So Dr. Chung, over to you.
Okay, thank you very much, Dr. Kumaran. Good morning, everyone. That's an excellent presentation by Dr. Lai. Happy Nurses Day to all of you. All right. My topic for today is an overview about promoting neuroplasticity in motor recovery post-stroke. As we all know, stroke is a very serious problem. It is the third leading cause of disability worldwide. Globally, from statistics, it is expected that 1 in 4 adults over the age of 25 may have a stroke in their lifetime. And even in Malaysia, stroke is the second highest cause of death. And every day we have almost about 100 patients being admitted across hospitals in Malaysia for stroke. And an interesting subsection of our patients are relatively younger when compared to other international data. So when the stroke patients are younger, it presents a better opportunity for neuroplasticity. But it's also said that the younger economic age group will be burdened by this potential disability. One of the problems about research and trying to prognosticate recovery after stroke is that it is a cluster of impairments, most commonly being cognitive problems, motor impairments, and of course upper and lower limb impairments will have its own trajectory, language problems, as well as a host of other problems. So later we will see that it is because of all the multiple problems that a patient may have, it's sometimes quite difficult to actually standardize stroke rehabilitation therapy. Of course, the best way to recover from stroke is not to have a stroke in the first place. So of course, we must always emphasize primary prevention, and if they had a stroke, secondary prevention. And of course, BPUM is a stroke center. We will always encourage patients to recognize the signs of a stroke and attend to the hospital as soon as possible. We do offer thrombectomy, thrombolysis services, and it has been shown to greatly reduce the disability and impairment after stroke. What we do know about a stroke, after a person has a stroke, it is usually the spontaneous recovery and maximum recovery within the first few weeks and first few months. As you can see from the slope here, the most rapid phase of recovery after the stroke is usually within the first few weeks, and it tapers down over time. Not to say that after 6 months there will not be any further recovery, but we see a golden period for us to intervene and actually promote further recovery. So most studies, actually, if you track the patient's recovery, actually it does show that within the first 3 to 6 months, there's most recovery. And this is where we actually plan to target that is this first few months, the subacute period after the stroke, the best window of opportunity for us to actually intervene. Okay, so there are various factors which may influence the functional recovery of stroke. Okay, but I would like to talk about neuroplasticity. So neuroplasticity has been defined as the ability of the central nervous system to adapt to changes in the environment. We used to learn, or we used to say that the neurons in the cells in the brain are fixed, so that any damage and there will not be any further recovery. But over the past 20 years, we have started to understand the concept that our nervous system is more plastic. It's not just in pathological states, but in also normal day-to-day life. In pop psychology, a lot of people are promoting neuroplasticity as a way to learn, adapt to changes, and cope with life problems. So it has been shown that any focal ischemic brain damage initially will lead to cell death followed by secondary damage. But then it also releases a lot of growth factors and a lot of potential for recovery during that period. Actually, some animal studies on rats have shown that after the rat has been induced with a stroke and so-called training was restarted 30 days after a stroke, there was limited recovery. But for those rats who have been had a stroke, training that was started within 5 days, and those rats actually shown better recovery. So the basis of the biological recovery will include things like axonal sprouting, dendrital branching, synaptogenesis, and neurogenesis. And this can be enhanced in the early post-stroke period. So Klein and Jones in 2008 actually listed out 10 principles of neuroplasticity. We will actually see how the therapy actually tries to follow all this. It's actually quite straightforward. You use it or lose it, meaning that you have to continue to use the affected limb to drive further recovery. Use it and improve it. The more you use, the more you challenge it, you actually improve the function. The type of training, the specificity, repetition, intensity. So again, you will hear these few words again and again, that the intensity and the repetition is important for you to learn that skill. Time matters. Again, usually you say that different persons may respond to training at different times of the day. Saliency matters. Actually, this is very important when it comes to stroke patients and rehabilitation, how important the therapy is to the how important the therapy is to the patient in regard to the patient's goals, their interests, and their motivation. So again, we're always patient-centered. It always goes back to what the patient wants. Of course, as mentioned earlier, the younger the patient, the more neuroplastic the brain is, the chances of recovery is further. And of course, the principles of transference and interference. I will probably add on to that in neural rehabilitation, we need progressive challenge, meaning you need to constantly push the patient to perform a little bit better, a bit more challenging exercises up to the tolerance of the patient. So you can see actually these principles are not to say very specific just for pathological conditions. Actually, we can apply it on ourselves on day to day, that if you want to improve, you have to practice, you have to be specific in your training, and you need the intensity and the repetition. So again, from popular psychology, some of you may have read the book Outliers by Malcolm Gladwell, where he proposed the 10,000 hours rule, that for people who are skillful or geniuses in their area, they will actually need about 10,000 hours of practice to actually achieve that level. So we will not debate whether it's already 10,000 hours or not, but just to show that you need intensity practice to actually improve on the skill. So what more after stroke? So the emphasis on promoting neuroplasticity is actually on the behavioral interventions. And by behavioral interventions here, we mean all the work done by our therapists, the physical physiotherapists, occupational therapists, speech therapists, and psychologists. So what input you put into the brain is very important for you to get the output. And when you talk about behavioral intervention, it really depends a lot of active participation from the patient to actually carry out the task within their ability. And of course, most of these approaches and most of the research will actually compare conventional therapy, which is again, can be defined according to the countries or the different hospitals, and with more advanced approaches, which I will go through after this. Okay, for motor recovery in the lower limb, most reviews have shown that for the immediate subacute period of post-stroke, it is advocated that all these patients should receive intensive, progressive, and task-related training. This can actually make a difference for those, especially who do not appear to be able to walk, and to get it within the first 3 months. That this actually will make a difference and improve their mobility outcomes. And with advancement in rehab technology, the recent Cochrane review has shown that those patients receiving physiotherapy in combination with electromechanical assisted gait training, or what some people refer to as just robotic training, will actually achieve better outcomes in terms of independent walking. So what are these electromechanical assisted gait training? Okay, and before we get to that, just again, Hornby and all in the publication 2020, who actually analyzed 3 different studies and about 140 patients, actually found that the only factors that actually predicted better gait outcomes was that those patients that received high intensity training, the highest number of practice sessions, and again, the greatest amount of stepping practice. So this is where the high intensity as well as the electromechanical assisted gait walking devices come in. Conventional therapy, the patient may not achieve more than 300 steps a day. They get tired, the therapist gets tired. But with some of this robotic walking, you can actually achieve up to 200, 2,000, 3,000 steps per day. And that is why we think that the assisted gait walking will actually change the way low-limb stroke rehab will occur. So besides the simple goals of repetition, the advances with technology, robotic training will also have other benefits: better motor control, cardiorespiratory efficiency, better participation engagement. A lot of this will have audio-visual feedback and gaming as well. So they will actually play a computer game as they walk. They actually get better feedback, engagement, and you actually get better monitoring of their improvement, and that becomes a motivation for them as well. So just to show some of the devices that is available, initially, most conventional therapy started with body weight supported treadmill therapy. You see on the picture on the left, the patient is actually hoisted on the body weight support and put on the treadmill, and the therapist will actually assist the patient to move the affected limb through the proper range of motion, and this is to practice the repetition of walking. But as you can see, in this kind of condition, it's tiring for the patient as well for the therapist itself, and therefore there's the feedback that you may not achieve that level of intensity and repetition needed. And therefore, most people have proceeded with robotic exoskeletons. This is the Hokoma Locomat. It's actually available in Malaysia, but not in our hospital, whereby you can see the exoskeleton actually supports the hip, the knee, and the foot bilaterally. The patient's weight is supported, and that can be adjusted, and the treadmill moves, and the exoskeleton can give full support or partial support to actually get the patient to walk. So a lot of research has been done on this kind of treadmill supported walkers to improve outcomes in spinal cord injury and stroke. What we do have in our center is Rehab Technologies dual system, somewhat similar to the Locomat. It is called the end effector, meaning that the only part that's attached is actually the foot, and this will appear in a stepwise motion to actually simulate walking instead of climbing, while the patient is actually suspended again, and there is a visual feedback for the patient. So again, it is said with these electromechanical devices or robotic trainers, you actually do get the repetitive motion, the training, the engagement, and as well the confidence and the safety. The patient feels supported, they will not fall. And of course, as technology advances, we have actually robotic exoskeletons that actually have overground walking as well. So the Cyberdyne health system is from Japan. The name Cyberdyne actually matches the Terminator company that produces a Terminator. I'm not sure the Japanese remember that or not, but it is available in Malaysia. I will show a video of that. Again, the patient has to be supported, while the walker actually uses a surface EMG to detect muscle activation to actually activate the motors. Another one that has been introduced in Malaysia is the Exobionics. Again, it's slightly different. For this, the patient does not need to be supported, and actually the therapist helps to support the patient from behind. Unfortunately, we do not have this in our hospital, but Cyberdyne is available in Malaysia under the Pokeso Rehabilitation Hospitals. This is a short video of how they will appear like if you were to walk on it. The first video on the left, which is the Cyberdyne health system. So you can see actually the patient is able to walk without the assistance of the therapist, and the patient is more motivated. They just walk around and around and around on themselves. They get tired, they rest, and then they continue walking again. So in a way, the exercise promotes a proper gait kinematics, proper range of motion, proper foot placement, and foot advancement. Okay. This is the Exobionics. They did a demonstration here back in 2019. So again, this is actually a spinal cord injured patient. So again, he needs a bit more assistance to stabilize. He still needs a walking aid. But again, the exoskeleton will assist him to taking the proper stepping motion. And again, there are many types of robotic walkers, I think, just that it is very expensive. Some of these technologies are available in the country, just that it is, again, very expensive. So hopefully we will be able to have some of this in our center soon. Okay, for upper limb. For upper limb, a lot of things that we do to achieve the, again, the principles of neuroplasticity, to have the repeated usage. I mean, to use it or lose it. Part of the problem with stroke is what we call learn non-use. We tend to compensate and use the unaffected side more. So in Constraint induced movement therapy introduced by Edward Thorpe in 1993, we actually restrain the good hand and force the patient to actually do the activities with the affected side. Of course, there are certain criteria. They need adequate partial recovery, at least motor power of 3, and at least 10 degrees of active wrist extension, thumb adduction, and digit extension for them to manipulate the hand. Of course, you can imagine this can be very frustrating for the patient, and you need a very high level of motivation to actually do that. So, I mean, that's why we tend to practice what we call the modified CMT, where we actually constrain the hand for 3 hours a day for 5 days instead of the original 90% of the waking hours. So again, it is a way to actually force the patient to use the hand. And what we find is that actually you need a lot of patient deep motivation, because it can be quite frustrating to do the task with an affected hand. And of course, if you have robotics for the upper limb, you can also have robotics for the lower limb. These are some of the things we have here on the 10th floor in Menara Selatan. We have the Hokoma Amir spring. You can see from the picture, it actually supports the shoulder, elbow, and the wrist for the patient to actually carry out activities, and usually it's in line with the computer screen and feedback. So in a way, when the patient plays a game, it actually encourages more engagement as well as repetition movement. So the other machine is a Fourier M2 motors. It is a platform base. You can see the wrist and hand is strapped on, and the movement that's allowed is either going front, back, left, right. Again, it can be used for patients who have very weak power. That means the device assists motion, or the patient uses their own monitoring motion to control the device, and there's different games and different feedback again for the patient. All this tends to try to rehabilitate the shoulder and wrist. There are other devices like some specific robotic gloves that try to rehabilitate the hand and digit function. We do not have that. So with robotics, we hope we can actually achieve that level of intensity and repetition as well as patient engagement. Okay, I will not talk too much about pharmacology, just that in stroke rehab, there is no magic pill, and because of that, there are other medications that people have tried. One of the most common one was fluoxetine. This is a SSRI. The initial study, the FLAME study, showed that it may benefit in motor recovery after a stroke, but subsequent studies with larger sample sizes, such as the focus, affinity, and effect, has shown that there was insignificant difference in motor recovery. However, some will question about the methodology of the research. What they do suggest is the patient has signs of post-stroke depression, fluoxetine may aid that. And of course, there are other medications that piracetam, Neuro8. Neuro8, interestingly, is actually a traditional Chinese medicine which has been made in a standardized pill form. It's actually available in Malaysia. Again, the studies that support the studies claim that there is long-term functional improvement, but again, it's not very convincing. I would like to focus a bit more on neuromodulation, on non-invasive brain stimulation. What we do have in stimulation here is a transcranial magnetic stimulation, and we do try some transcranial direct current stimulation. So what are these neuromodulation? So neuromodulation can be defined as the alteration of nervous activity through targeted delivery of a stimulus such as electrical stimulation or chemical agents to specific parts of the neurological sites in the body. So as this is non-invasive, so transcranial magnetic stimulation is not just magnetic therapy, it's not putting a magnet to your brain, but basically it's actually using a large machine and a magnetic coil to generate an electrical current in the brain, as you can see here. Okay, so when we induce a magnetic field in a coil, you actually induce an electrical charge in the area surrounding it. So you can see in the picture on the right, the TMS coil will induce a concurrent counter eddy current around it, and when it's put on top of the cranium, you will actually induce the electrical current within the cortex of the brain. So we are inducing electrical current in the cortex of the brain. So we can use it for diagnostic purposes. We have used it for prognostication. When we induce electrical current in the brain, you can actually measure and evoke potential. It actually stimulates the neuron. You can actually measure that through surface EMG, motor evoke potential. There are certain protocols that we can use it to sort of prognosticate recovery after a stroke, especially in upper limb. If there's a motor evoke potential detected, that means the motor pathway from the cortex to the affected organ, the muscles is intact, and therefore the patient should have a better chance of recovery. But for therapy, we actually use repetitive transcranial magnetic stimulation. Basically, there are few protocols, meaning you can induce lower frequency stimulation impulses or higher frequency, which actually is inhibitory or effectory respectively. And of course, it is not just doing this, it's actually pairing the neuromodulation with therapy, using this to help affect the motor relearning. So most of the neurostimulatory non-invasive brain modulation is actually based on the interhemispheric competition model, meaning that after a stroke, a patient will have reduced output from the affected hemisphere or the lesional hemisphere, and on the contralateral unaffected hemisphere, there will be excessive interhemispheric inhibition, which actually may delay recovery. So one of the proposed treatment with non-invasive brain stimulation is to actually inhibit the unlesioned hemisphere and excite the lesioned hemisphere. So to understand it easier in pictures, in a pre-stroke, you expect the interhemispheric balance between both sides. Post-stroke, the area in blue is the affected site, and therefore there'll be less output coming from the affected site and more inhibition, unbalanced inhibition coming from the unaffected site. So one of the proposed usage of non-invasive brain stimulation is actually to inhibit the non-lesional site so that you reduce the interhemispheric inhibition, or you stimulate the lesional site to actually increase the output from the brain. So TMS is not new, but you can see over the years since the 1990s, more and more research is being published, and we are trying to better understand the applications of TMS in rehabilitation. All right, so this is one of our patients that we're doing. Actually, most of the TMS work here used to be done by Professor Lydia, and now Professor Maslina is doing it. So you can see this patient actually had a stroke on his left hemisphere, and he has a right-sided weakness. And for this gentleman, we are using the inhibitory protocol, whereby we try to inhibit the right hemisphere, which is the normal hemisphere. We will use the TMS machine to actually map and find the M1 motor area. You can see we actually put a swimming cap on top of the patient and mark it with dots to try to mark it. Our protocol, we tend to follow a 10-session, daily session therapy. So the patient will wear the same cap to mark the right area so that we know the area to stimulate for the subsequent RTMS sessions. So unfortunately, most of the systemic reviews would suggest that RTMS is a promising tool for stroke rehabilitation. It suggests that it has positive effects in all aspects of rehabilitation except for spasticity and cognitive impairment. However, it is not a gold standard recommendation yet because the protocols is actually still not determined because of the heterogeneity of the research in terms of protocols. Some will stimulate once, some will stimulate 5 times, 10 times, 15 times, the area of stimulation, the intensity of stimulation. Now, these are all parameters that we still need to research on as well. So RTMS is not just used in stroke rehabilitation. For psychiatric, depression, chronic pain, all has been indicated for usage of the RTMS. Another similar non-invasive brain stimulation is the transcranial direct current stimulation, whereby it's actually just putting 2 electrodes and on the cathode on top of the brain, and actually you induce a weak current of 2 milliamps. And it is believed that 10-20% of current that penetrates the cranium will actually lead to excitatory or inhibitory function of the neuronal excitability. And again, this is Marian Bixen, one of the top researchers. So you're actually basically putting 2 electrodes. The red wire is the positive anode, the black wire is a cathode. And if you do a representation, you're just inducing a current, a very small current through your brain, and it's believed that this changes the excitability of the neurons. And when you do it with therapy, you actually prime the brain to make the brain more susceptible for learning. So we do not have a TDS machine in the hospital. We actually loan it from the various companies to trial on our patients. The picture on the left is actually a wireless TCDS. Actually, he wears a cap, and actually there's 2 electrodes, and and it's controlled wirelessly by a battery. And through the laptop, we actually control the application of the current, the intensity, and the duration of the stimulation. Okay, this is a picture from a patient in the ward. This is a wired TCDS. This is the control box. You see 2 wires leading, and we actually use a bandage to actually attach the electrode. It is very safe. Most patients complain of some tingling sensations. This is an example of using it for speech in this picture. It's online therapy. We actually stimulate while doing the therapy. Some studies suggest that you can also do it within a few hours after the stimulation. There will be carryover effect. This is just a sample of one of the patients' handwriting before and after TCDS. And the patient was quite surprised himself that his actually motor control actually improved, and he was able to sign his name and write a bit more intelligibly after the neurostimulation. So again, TCDS started a bit later in the year from 2000 onwards. Again, more and more interest is in TCDS. I think partially because also it is a cheaper machine, it is easier to apply, and it is a bit less adverse effects compared to RTMS. Okay, so again, the systemic reviews of the TCDS is similar to TMS again. There is potential benefit, it may help, but again, because of the heterogeneity of the protocols and the data and outcome measures, there is no strong recommendation for it yet. So this is my last slide. I will want to show that actually the core of training for motor recovery will be the behavioral approaches, repetitive, intense, task-specific, challenging exercises. Again, if you can introduce more advanced approaches like robotics, and of course, with the support of possible neuropharmacology and neuromodulation to actually improve the outcomes along with those behavioral approaches. I think that's the end of my talk.
Right. Thank you very much, Tze Yang. That was a very comprehensive presentation on neuroplasticity. We can quickly respond to some of the questions.
Okay, I think Prof. Chan has asked, how does robotic training improve the outcome? It moves the limb, but the control area in the brain benefits from the increased blood flow. Actually, it's through the repetition. The more you repeat the movement, if there's intact motor pathway, you actually strengthen the synaptic connection and the pathway. Again, things are changing, things are improving. It's not just passive movement. For example, the Cyberdyne uses surface electrode. They actually detect the muscle contraction to time the movement of the gait training with the patient's contraction. Some people are working with functional electrical stimulation as well. Along with the gait training, the robot actually stimulate the muscle, appropriate muscle at the appropriate phase of gait, again, for the patient to learn to activate the correct muscles in the correct time during the gait phases. Again, it's still new, data is still coming in, and I guess one of the problem is the affordability of the machines. So,
Yep. So we have a question from Prof. Tengku Sara on the chat as well.
yeah, so how to enhance transference and reduce interference? Okay, so the concept of transference is that certain activities that you do may improve your outcome. For example, post-stroke patients may have plantar flexion because of specificity of the lower limb. So when they walk, they tend to have a foot drop. So exercises that increase the dorsiflexion, for example, tibialis anterior, you keep stimulating that, exercising that, they actually get better dorsiflexion. That can improve their gait training. Interference is actually exercises that you do which may interfere with the recovery. For example, in compensation, when you have a stroke, we teach the patient to walk fast. For example, with a quad cane, they will actually shift their weight to the unaffected side. They will actually bear weight more on the unaffected side. So in the terms of recovery for the affected side, meaning there's less stimulus, they learn not to bear too much weight on the affected side. That may interfere with recovery of the affected limb.
Yeah. So,
and
would EM work in the same way as, I suppose that's low-level laser?
We are not too sure about that. I know there are some people who are proposing low-level laser as a transcranial stimulation to the brain as well, but I think those are still in preliminary research. And that is something also we are looking into. We are actually approaching some companies if we can sponsor some of their transcranial low-level laser helmet stimulation.
Right, good. Tze Yang, if I may just conclude with one last question. There are many players in this neuromodulation area. We've had magnetic stimulation and then electric current stimulation, and the latest, I suppose, would be the light stimulation or photobiomodulation. Which one do you think is going to, all three have got their roles, or one is going to dominate?
I think there's not enough data for us to know which is actually the better ones. I think a lot of people are excited, they're doing all sorts of things. I think the advantage of all this is relatively safer. So a lot of people are going all out for that.
Right. Okay, thank you. With that, I have to conclude the presentation today. I also would like to wish all the nurses Happy Nurses Day, and also Selamat Hari Raya to our Muslim colleagues who are celebrating.
Selamat Hari Raya.
Right. So thank you, everyone.